Good afternoon, everyone. Thank you so much for being with us today, both in person and online. My name is Michelle Wazan, and I'm the Drug Policy Program Manager at Skoun, a harm reduction organization working in Lebanon since 2003 for the protection and the promotion of the rights of people who use drugs in Lebanon. This side event is organized in partnership with MENA and Frontline AIDS, who are both represented online. I'm honored to be moderating this panel of experts from across the world and from communities, UN agencies, and civil society. Unfortunately, not everyone has been able to make it in person. It is undeniable we are in crisis. The funding cuts and the attacks on gender rights affect all of our human rights and jeopardize so many achievements made in the past decade. It is a crisis that will no doubt disproportionately affect people who use drugs, particularly women, LGBTQ individuals, and different vulnerable groups. This makes our conversation today all the more timely and relevant. For decades, states have repeated their commitment to gender equality and gender mainstreaming in policies, declarations, and resolutions. Yet the discriminatory legacy of repressive policies and of drug control on different populations continue to disproportionately hamper the realization of the human rights of all women, as well as gender diverse individuals, particularly those in vulnerable situations such as migrants, refugees, people living in poverty, individuals engaged in sex work, women in prisons, LGBTQ individuals, even more so in places where they're criminalized. We at Skoun have conducted a participatory needs assessment in Lebanon among 5 groups of vulnerable women on the links between substance use and gender-based violence. Our assessment was conducted before the devastating war in Lebanon, which led to the internal displacement of over 1 million people, and before the funding cuts. Our findings were dramatic then. If we are to look at it in a couple of months and do the same assessment, the situation will no doubt be catastrophic. If you're interested in the findings of our assessment, we have some copies at the end of the room. And the report will also be put on the chat by our Executive Director, Tatiana Sleiman, behind the screen to my left. Thank you so much, Tatiana, for your support. Finally, before ceding the floor, I would like to thank our co-organizers, our co-sponsors, and our panelists for their time and support. And we would like to thank the Women's Peace and Humanitarian Fund Window for Human Rights Defender for making Skoun's presence at the CND possible. Our opening remarks are going to be given by Boyan Konstantinov, Policy Specialist and HIV Health and Development at UNGP. Thank you, Boyan.
Thank you very much, Chair. Good afternoon, dear colleagues, dear friends. It is, of course, an honor to join you today for this important conversation on gender inequalities and drug policy. We are here, I hope, not only to discuss policy, but also to advance an agenda that ensures that human rights, dignity, and health for all includes women, girls, and gender diverse people who are affected by punitive drug policies. I hope we also have the time to touch against the global pushback on human rights in civic space, which has its origins, as we know, and is closely related to the pushback against the rights of women. We all read the World Drug Report. I hope we do. In 2024, it again highlighted how women who use drugs face systemic barriers to accessing treatment, a reality which is compounded by stigma, by discrimination, and punitive legal frameworks. I remember one fact that despite women making up nearly 40% of the people who use amphetamines, account only for 20% of people who receive treatment. A huge gap, which illustrates the deep flaw in our health and social support systems. We know that many women avoid seeking care due to fear of criminalization, losing custody of their children, or facing violence either at home or from the authorities. Women who use drugs also experience significantly higher rate of intimate partner violence and sexual violence. A woman who injects drugs is up to 10 times more likely to be living with HIV compared to a man who injects drugs. due to the intersecting vulnerabilities such as economic dependency, social stigma, lack of access to harm reduction services. And these are, of course, numbers, but they also represent real lives and real people whose health and rights continue to be ignored. Youth, particularly young women, girls, as well as gender diverse young people, they face higher risks as early drug use is often linked to experiencing trauma, poverty, exclusion. We saw what happened during the acute days of the COVID pandemic. Yet, young populations remain underserved by harm reduction and treatment services, which are traditionally designed for older populations. And their needs, including in the context of gender, are not always taken into consideration. The evidence is clear. Criminalization does not reduce drug use. It only exacerbates harm. Nearly 7 million people were in contact with the criminal justice system for drug-related offenses, as we heard many times over the past few days, and 2/3 of them were for personal possession. That doesn't yield very good public health and human rights result, and also cost an enormous amount of money, as we can well imagine. Women who use drugs are disproportionately affected with higher rates of incarceration for nonviolent drug offenses. And once in prison, they face compounded risks such as limited health care, exposure to violence, inadequate access to harm reduction. For pregnant women, the situation is even worse. Many are denied essential care. Many are forced to give birth in degrading conditions. Many are separated from their newborn children. The international guidelines on human rights and drug policies, I hope you heard about them at least a couple of times over the past few days. They make it clear that drug policies must be aligned with international human rights obligations, including the right to health, including non-discrimination and gender equality. States must take concrete steps to eliminate these barriers that prevent women from accessing harm reduction and healthcare services, and to ensure that legal and policy frameworks prioritize public health over punitive approaches. We're not there yet. This means that we must move away from these carceral approaches and invest in health and social justice responses that work. We must ensure that harm reduction services ranging from needle and syringe exchange, opioid agonist maintenance therapy, overdose prevention are fully accessible to women and gender diverse people. We must also integrate reproductive health services into drug treatment programs, so women do not have to choose between seeking care for the drug use or their pregnancy. And we need to meaningfully include women as well as gender diverse people who use drugs in policy making, ensuring their voices are heard and their experience and expertise are recognized and used. To advance gender responsive drug policies, we must listen to the voices of the people who are affected. We must push for decriminalization of drug use, scale up harm reduction services tailored to women and gender diverse people and youth, and ensure that policies uphold their rights rather than punish them. This is not just a health issue. It is a development issue, it is a gender issue, and above all, it's a human rights issue. At UNDP, we remain committed to working with all of you to build systems that put people first, ensuring that no one is left behind in our responses to drugs, health, and justice. Thank you.
Thank you so much, Bayan, for this great overview. And I think our panelists here today are going to go more into details and unfolding these issues, but also the recommendations you have made. So now, so as you've mentioned, criminalization plays a big role in undermining the human rights of different communities, but it also affects the efforts to end AIDS. I'm now going to give the floor to Emily Christie, who's with us online. She is the Senior Advisor for Human Rights and Law at UNAIDS and the focal point for drug policy. Her work includes engagement with the Human Rights Council, the Commission on Narcotic Drugs, and development of human rights norms and standards, as well as supporting countries in relation to decriminalization. Thank you so much, Emily, for being with us. The floor is yours.
Thank you very much. Can you all hear me okay?
Yes.
Great. I want to thank everyone for coming today, and I'm very sorry that I could not be there in person. And I want to thank the organisers for this event and for making space to be able to talk about gender and drug policy. I've been asked to speak a bit about the global AIDS strategy and targets and where we are, particularly in relation to women who use drugs, as well as sort of the recommendations that UNAIDS have on this, and a little bit around the new strategy that's coming out and opportunities to engage on that. So what you have on the slide in front of you at the moment are the societal enabler targets, which I will talk about in a little bit, and I'll start a little bit on the biomedical ones first. So as you know, in 2021, we had a new global AIDS strategy. It had specific targets for people who use drugs. The biomedical targets included coverage of 200 sterile needles and syringes per person, as well as 50% opioid agonist therapy, as well as access to combination prevention, and of course the 95-95-95 targets on treatment and testing. As you know, it's difficult to pull together a complete picture for women who use drugs because disaggregated data is scarce. A lot of the time when we ask around this and trying to get more data, people will say they're difficult to find, or the numbers that we have are so small that it's difficult to report on. So more work really does need to be done around this to make sure that we can ensure women are represented in the data that is there. And great to hear that there's been some studies done, and I look forward to reading that one as well. So thank you for doing that work. What we do have does indicate a continued elevated risk of acquiring HIV and a reduction in access to services for women compared to men. Next slide. So we reported last year, if we just look across everybody, all genders combined, we reported that the median prevalence amongst all people who use drugs is around 5%, which is 7 times that of the adult population generally. And it's 8% of all new infections in 2022, which is what you can see on the screen, just slightly higher than it was in 2010. There's only 18 countries that actually report disaggregated data on prevalence. And what we have amongst those 18 countries is that it's almost twice as high among women. So it's 8.5% prevalence amongst men, 15% amongst women who inject drugs. If we look at access to services, while there does seem to be parity in the use of sterile needles at last injection, at least in the data that we have, for the 9 reporting countries with gender disaggregated data on opioid agonist maintenance therapy, coverage is 9.4% for men and 3.4% for women. Both are still really low, considering that the target is 50%, but you're seeing almost 3 times lower for women than for men. Within the global strategy, recognizing that access is not simply about availability, but also affected by stigma, discrimination, criminalization, and a lot of the factors that Boyan just spoke about as well that prevent women in particular from accessing services. The strategy includes the societal enabler targets, which you saw earlier. So if we can go to the next slide. This is a little bit hard to read, I recognize, but these are the 3 main targets in the societal enablers in terms of stigma and discrimination. So you've got on the left, avoidance of healthcare, in the middle, experiences of physical and sexual violence, and on the right, you've got experiences of stigma and discrimination in the past 6 months. This is all amongst people who inject drugs. The target is the red line, which is 10%. So anything below that are countries that have reached the target. Anything above it are those that haven't. You can find this graph in our Global AIDS Update report and in the fact sheet that we did at the same time around people who use drugs. So you can have a look at which countries are which. We don't report publicly in this update report on disaggregated data because the numbers that we receive are so small. But you can find it on the Key Population website. And so I did a little bit of digging with our DFI team. And to just give you an idea, if we're looking at countries where we're looking at experience of stigma and discrimination, in 4 of the 5 countries with data, the experiences were higher amongst women than men. If you're looking at avoidance of healthcare, there were 12 countries that had disaggregated data, and it was higher again for women in all but 3. And then if you're looking at violence, it was high for women in 6 out of the 7 reporting countries. I know that's a lot of different numbers, but basically what we're saying is in the majority of reporting countries with disaggregated data, experiences of stigma, discrimination, violence, and avoidance of healthcare are higher amongst women who use drugs compared to men. Please use these data with caution. Some of the denominators are below 100. So we've got a lot of uncertainty bounds in there. We also know from GMP Plus in their analysis last year of the stigma index that stigma and discrimination is higher in non-HIV services compared to HIV services for people who inject drugs. And this is going to have a significant implication when we're looking at the funding cuts and moves towards integration that we're seeing in some countries. UNAIDS also supported ICW to do a global scan on coercive reproductive practices against women living with HIV, and this included women from key populations. And this found that women with a history of drug use were more likely to experience coercive practices in terms of SRHR than women without a history of drug use. And so this is including things like forced or coerced sterilization, requirements to be on contraception, and if you are wanting to take HIV medication, and also coercion in terms of pregnancy and feeding practices. So moving on to decriminalization, we do have the target that, it's not quite this slide, but you can keep that one up. We do have the target that countries, less than 10% of countries criminalize small amounts of drugs. And actually the broader target is generally more about removing those punitive laws and policies that create barriers to accessing HIV services. So when we're talking about decriminalization, it's a much broader look at what are those punitive laws that are impacting on access when we're looking at law reform. And we know that there is a disproportionate impact on women who use drugs and higher rates of incarceration. So only 29 countries are reporting to UNAIDS that they do not criminalize possession of drugs for personal use. And if we're looking at data from community groups, it's 39, which is not that much more and still far below the target. We also see high rates of criminalization in terms of LGBT communities and sex workers, which we know has a multiplying effect where you have people who are members of different key population groups together, because the law enforcement practices aren't always targeting you for the particular criminal law that you think they are, as we know. If we go on to the next slide. So this is the one on community leadership within the response, and that community-led organizations should be involved in decision-making. And we're talking about advocacy around societal enablers. It's supposed to be around 80% leadership or involvement. And what is being shown on this graph here is actually when you're talking about people who inject drugs and communities led by people who use drugs, they are the second most excluded group out of key populations, people living with HIV. The only one that is more excluded are prisoners. So what this is all saying in a very depressing way, is that for people who use drugs, particularly women who use drugs, we're nowhere near meeting the 2025 targets, which are for this year. And with recent changes to funding, it's very likely we're going to fall further behind. Of course, work is being done and continues to be done, not only to make sure that people are able to access services, but generally around access for women who use drugs. UNODC released guidance last year on gender-based violence for women who use drugs, which has a lot of information there generally around how to make sure services, harm reduction services are accessible, and UNAIDS was also involved in that. We know that countries such as Kenya, Brazil, and Nigeria have policies and harm reduction services that are specifically aimed at women. And of course, as Boyan mentioned, there's the international guidelines on human rights and drug policy. So just the final slide on moving forward. We know that things need to change in terms of how we do harm reduction, how we do HIV services for women who use drugs to make sure that they are more accessible. Sorry, final slide, if you can. And we have a new strategy that's being developed this year. And this is where it's my turn to ask the audience here to get involved. The strategy will be an open and accessible one for everyone. There will be a survey that is going online in the next couple of weeks, so keep an eye out for that. We are also going to be doing regional and global consultations If you have questions around that and how to get involved, you can contact me or you can contact through the organizers here, and we can put you in touch with the people who are running the strategy process. You can also run your own consultations and send through submissions to us, and particularly in relation to the topic that we're talking about today and what that is going to look like in the future, and how do we create a response for the next 5 years that gets us to 2030 and doesn't leave women who use drugs behind. We really would love to get everyone's inputs into that to make sure that women who use drugs are at the center, are in leading positions in relation to development and implementation of programs, that services are adapted and appropriate, and that we make sure that human rights are at the center of that. So thank you very much.
Thank you so much, Emily. And we're glad that the UNAIDS upcoming strategy is going to be a participatory one. And I think to my left, Teresa and Angela will be talking more about the importance of the participation of affected communities. As for the recommendations, we definitely agree that criminalization, including the criminalization of LGBTQ individuals and of sex work, have, and of course of substance use, have failed, and they have only led to negative outcomes. The situation is even more dire in systems where extreme penalties are enforced for drug-related charges. And now I am pleased to pass the floor to Sarah Bilal, who's the Executive Director of Justice Project Pakistan. She's the executive director and the founder, which is a legal action nonprofit organization established in Lahore in December 2009. JPP, or Justice Project Pakistan, represents the most vulnerable Pakistani prisoners facing the harshest punishments at home and abroad. Thank you so much for being with us today.
Thank you so much for inviting me. Okay, so we are going to talk about my country, Pakistan. That up until very recently has had a very tumultuous relationship with drug policy. In fact, it was a drug policy that was solely considered within the security paradigm. But just as to give you a background framing, 2 years ago, something miraculous happens that often happens in my country, which is that our country abolished the death penalty for narcotics offenses. I know, and I think they deserve a round of applause. Malaysia gets a lot of credit, but they'd only removed the mandatory death penalty. Pakistan is a Muslim nation. They removed the death penalty completely. However, that basically led to us, who were traditionally death penalty folk, kind of getting into the drug policy space because we saw an opportunity to actually engage in a conversation and to bring this conversation into the public realm, public and policy realm. And last year, so we're kind of, bear with us, our stats and everything are sort of new because we're getting into this space. And, last year we were asked to host a national policy dialogue. And we realized in the process of hosting it that it was the first time that a national public dialogue had ever been held in our country. And I'll come back to it, but it was a fantastic moment because you saw an incredible impetus for change from the national institutions, such as the police, the prisons, the ministries of law, the ministries of human rights. So there is a real drive and impetus right now in Pakistan around drug policy. And I urge all of the experts and all of the NGOs and the CSOs, everybody to don't count us off, but actually engage with our country because this is a magic moment and we want to make sure that we continue. Okay, back to the stats. So the war on drugs has disproportionately impacted women globally. Obviously, we know that. In Pakistan, however, 375 women are currently incarcerated for drug offenses, even though that's only 1.7% of the total narcotics prisoner population, yet they make up 40% of those on death row for drug-related offenses. So even though we abolished the death penalty for drug offenses, there's still 20 people on death row. 8 of those are women. So I think the figure is like they're 38 more times likely to have been sentenced more harshly. Pakistan's main act that regulates that regulates the drug trade is the Control of Narcotic Substances Act that was made in 1997. It enforces harsh penalties, obviously without addressing gender-specific vulnerabilities, does not take into account the factors that influence women, which, they face coercion, poverty, or manipulation, and stigma, et cetera, et cetera. I'm going to try not to repeat myself with what other panelists have said. Drug-related offenses are the second most leading cause of incarceration for women in Pakistan, and their numbers continue to rise. As in the global average, women in the drug trade in Pakistan perform high-risk, low-level roles in a male-dominated illegal economy, making them more likely to be arrested and imprisoned. Now, also, Pakistan's drug laws do not reflect the complex realities of women's involvement in the drug trade. Then again, once the women are incarcerated, they face myriad challenges inside and outside prison. And unfortunately, despite being an active member of the international community, and in recent times, the last 14 years, Pakistan has done a lot to actually implement its international human rights obligations. We've had several reviews before the Human Rights Committee. The Convention Against Torture. We've had traditionally a very good record of reviewing regularly by the CEDAW Committee, but we don't see those UN minimum standards, such as the Bangkok rules, being reflected in the prison rules. We're still dealing with the laws that the Brits sent over. And unfortunately, Punjab, which is the largest province, has over 60% of the prison population, has not revised its rules. And you can read about that on our website. Women in Pakistan prisons. So in 2023, 1,782 individuals were arrested under the CNSA. And women accounted for 8% of those arrested. As of January 2025, we have a total population of 21,000 individuals who are imprisoned for drug offenses under the CNSA, and they represent 21.39% of Pakistan's total prison population. Now, when you look at the very high rate of overcrowding that we have in prison, this baseline figure of 20% was added when there was an amendment to the CNSA in 2022 that actually had disastrous consequences and directly led to this number of 20,000 being added to the prison population. I mean, the number we came up with was like about 12,000 in just 12 months alone. And that is because the 2022 amendment to the CNSA added mandatory minimums, maximum penalties for repeat offenders. It eliminated remissions under the Pakistan prison rules. So it did not include any possibility of reductions. And it also extended the remand period for investigation into these offenses to 90 days, which is what we have for terrorist offenses. And just to give you an idea of the maximum and minimum penalties, I've been a death penalty lawyer for 15 years, and murder is punishable by death or life in Pakistan. Life imprisonment is construed under our law to be 25 years. And with remissions, you can effectively come out in 15 to 17 years. But the mandatory minimum that's been introduced for drug offenses for a certain quantity of drugs is, 2023, the death penalty was removed, but in 2022, under this amendment, it was life or death. And with life, it said you have to serve a minimum of 20 years. So, it was tougher it's worse than killing somebody. So 83% of the narcotics prisoners in Pakistan are under trial. They often spend years behind bars without a conviction. Obviously, probation, parole, and bail options have largely been eliminated by the law. I'm going to skip over the pathways to crime, and I think I'm low on time, so I'm going to talk straight about the recommendations for legislative reform. Well, sorry, there's certain parts of the act that have made it much more for women. So women prisons in Pakistan, obviously they lack gender-sensitive facilities, including reproductive health care, mental health support, rehabilitation programs. Vocational training and mental health services are inadequate, and the compulsory registration of individuals as addicts under Section 52 of the CNSA discourages women from seeking voluntary treatment or harm reduction services. The way that we approach it with the government of Pakistan when we give them technical advice is we couch it in very utilitarian terms. You don't have a massive overcrowding problem, right? You don't need to be building new prisons. You don't need these 20,000 nonviolent offenders in prison. And that effectively reduces 20% of your prison population, right? You need to reverse the 2022 amendment to allow women and children and all the other ones also to have bail and probation. It needs to be rolled back. It's not worth your time. It doesn't also comply with your more shift towards a more harm reduction national policy on drugs that inshallah we're going towards. So the key recommendations are: we need a reform of the bail and pretrial detention laws. We need non-custodial alternatives. The initial law does not differentiate between users and traffickers. And that obviously also kind of really affects women. To give you an idea, we were doing a judicial training for the federal judicial course on the international guidelines on human rights and drug policy. And what we found was that the trial court judges, the CNSA drug court judges, were incredibly frustrated at the lack at their discretion being taken away. And that was across the board from all 4 provinces. And, they cited examples of a woman who was 77 years old. These are women in the household of a famous trafficker. And, the trafficker, when caught, was framing these women instead of taking the blame. And these women had much less access to proper legal help, and they were sentenced much more harshly because of the biases that exist against them. But I believe in good news. And so I'm here to tell you that despite these overwhelming statistics, there is genuine change happening on the ground. So at the National Public Policy Dialogue, which was the first one ever, the law minister, the current law minister, and the incoming Chief Justice at that time, so senior members of the judiciary were present. And when they heard about the 2022 amendment, they immediately pledged a reform of the laws. And we know for a fact that our Ministry of Law has called for comments from all quarters to actually roll back the law. Secondly, we found the judges to be very much on board, and they're willing to engage. So we're launching an e-training course on the international guidelines this month. And I think we have also a very senior member of our justice ministry. He's a member of state, he's a member of the cabinet, who's been here soaking up and engaging in bilateral dialogues and really learning from the experience of Latin American countries and other countries in terms of their drug policy. So I'll end by saying that my country is at a very critical juncture in its drug policy thing and in its drug policy journey. And I really believe that you're going to see some good changes and good evolutions in the coming years. So please focus on this country, because this is the time when we need that support from a CSO, from a multilateral, from a diplomatic, and all other kinds of support so that we can actually get this done. Thank you so much.
Thank you so much, Sarah. We really hope that Pakistan is on the right path and that for meaningful reforms. Also, thank you for mentioning the Bangkok rules and the Nelson Mandela rules, as our next speakers are from Lebanon, and they have conducted a groundbreaking or first of its kind research among women in prisons across the MENA region, and they will be presenting to us their findings. So we have with us both Eli Araj and Isabel Saleme from the Middle East and North Africa Harm Reduction Association. So Eli Araj is the executive director of MENA, with over 30 years of experience in HIV, AIDS, and harm reduction. He founded SIDC in Lebanon during the civil war, later expanding its focus to include HIV, AIDS, and addiction. He advocates for transformative harm reduction practices across the MENA region. As for Isabel, she's the program coordinator at MENA. She has a bachelor in public health and master's in public health from the American University of Beirut. The floor is yours.
Hi, good afternoon. Thank you, Michelle. We as MENA are glad to co-organize this side event with Frontline AIDS and the Skoun, with whom we have really a strategic partnership since many years, and it will continue. We are glad also to have some of us in Vienna, but also for sure we are frustrated because we couldn't make it this year due to the I think madness that is ruling the world. The working on women's services in the MENA region is very difficult in general. When it comes to harm reduction services in the prisons for women, this is more and more difficult. We have conducted the part related to the data collection and the literature review in this study. And here we found very scarce information. This is the first part. The second part will be more in-depth interviews and data collection from key stakeholders and ex-prisoners at least. And maybe we will see what to do in the future. I will leave the floor to my colleague Isabel, who will be sharing with you the findings of this study. Thank you.
Hello, everyone. I'm delighted to share with you the findings and recommendations of the scoping review on harm reduction services in female prisons in the MENA region. This study is conducted by me and by Isabel Saleme and by Mr. Eli Araj. And to our knowledge, this is the first study to explore the availability and accessibility of gender-responsive harm reduction services in female prisons in the region. I will not go through the details for the sake of time, and I will move directly to sharing with you the findings and recommendations. So out of 2,730 identified records that were published between 2014 and 2024, a total of 25 records only have met the selection criteria and were included in this review. Most of the studies, I will move to the findings now. So most of the studies did not differentiate between by gender and did not prioritize in specific the needs of women who use drugs, limiting our understanding to or of the needs of women who use drugs. While some services in female prisons were reported in some of the identified records, their adequacy and effectiveness for women who use drugs were understudied, and they were mirroring the services in male prisons, neglecting women's unique needs. And even when female-operated services were reported, their effectiveness and availability in prisons remain unclear. The same applies for the post-release services. It was also reported that women in prison face stigma, humiliation, poor mental and physical health, and inadequate support for ART and OAT adherence. In addition, mixed views among prison staff created additional challenge to implementing harm reduction services. Some reports indicated that screening and medical evaluation in female prisons are insufficient or inconsistently implemented. Reports also highlight poor STI knowledge and risky sexual behavior, in addition to lack of knowledge on harm reduction and available services. Shortage in space, staffing, and budget were reported to hinder effective service provision. One of the major identified gaps also is the lack of formal assessments, monitoring and evaluation, and impact assessments of harm reduction programs and services. I will now move to our recommendations. So first, resources and efforts should be allocated to conduct research on gender-specific needs in female prisons, to study gender differences in service provision, and to explore the neglected needs of women who use drugs. Approaches and interventions that are evidence-based and gender-responsive should be designed, and implemented taking into account the region's sociocultural and religious values. Interventions addressing gender-based violence, trauma, and comorbidities affecting women who use drugs should be implemented. Screening, diagnosis, and treatment strategies should be re-evaluated and improved to meet the specific needs of women who use drugs in prisons, and inconsistencies in health screening should be addressed. Also, educational campaigns and peer-led education should be conducted to increase awareness on STIs, harm reduction, disease prevention, and available services in prisons. Capacity building for all prison staff, all of them, on gender-specific needs, harm reduction approaches, and the importance of non-discriminatory healthcare access should be conducted to improve service delivery, reduce stigma, and to ensure adherence to quality standards and guidelines. It is also very important to ensure non-judgmental, safe spaces to promote connections with children, family, and community. Access to gender-sensitive healthcare, harm reduction services, and mental health support, and social reintegration programs post-release should be ensured. And in order to improve the quality and sustainability of harm reduction services, adequate resources should be allocated, and partnerships with civil society organizations and healthcare providers and international stakeholders should be strengthened and maintained. And in order to measure the impact of services and ensure evidence-based decision-making, monitoring and evaluation mechanisms should be in place. In addition, disaggregated data on women who use drugs should be collected to be able to assess their needs and service effectiveness. Finally, community engagement and multi-sectoral partnerships are essential to ensure a comprehensive harm reduction response. Affected communities and their networks should be always involved in the design and implementation and evaluation of services. And partnerships with stakeholders at all levels are essential to promote best practices and policy reform. Thank you very much.
Thank you so much, Ali and Isabel. Thank you, MENA, for co-organizing this side event. It's striking from these findings, at least even if they're preliminary, that how much the carceral system and prisons are not made to absorb people who use drugs. There's also another discussion that has to be done about prisons reform, maybe prison abolition. So outside of jail, the criminalization of substance use plays a role in perpetuating cycles of violence, both interpersonal and structural, against women and gender-based and gender-diverse individuals who use drugs. We know that women who use drugs are subject to rates of violence that are up to 24 times more than women who don't use drugs. So I'm just going to do a little more promotion. We have our report that tackles this specific topic, which is at the end of the room. You can take a copy on your way out. Before I give the floor to Angela McBride, who is the executive director of the South African Network of People Who Use Drugs, SANPUD, and also a woman who uses drugs. I just want to mention that SANPUD have been working on a number of community-led initiatives, including one that particularly addresses gender-based violence. I give the floor to, thank you, Angela, for being with us.
Thank you, and thank you so much, everyone, for joining. I'm really grateful to be able to share this work that's been done by SANPUD, some really incredible women, people back home in South Africa. And today I'm lucky enough to be able to share some of the incredible work that is being done, in particular by women who use drugs, for women who use drugs, and just finding ways and examples and addressing the inequalities, addressing the compounding, as it says here, compounding vulnerabilities that we do face on a daily basis. So if we can move on to the next slide, please. So at SANPUD, in our organization, working with our community, it's all about advocacy and action. We look at addressing the harms that punitive policies play in the lives of women who use drugs, such as targeting women who are homeless and or unemployed, and stigmatizing women based on what we choose to do with our body, whether it's judging a mom, judging a fellow, turning someone away from services. But that doesn't achieve anything. If anything, and we know, we saw a few of our panelists have even mentioned, there's so much research that shows stigmatization, judging, that just leads to more harm. It leads to people not being willing to access services, and that just builds up, and it's avoidable harms. So instead of stigma, instead of judgment, rather action, inclusion, and compassion. We have worked with some incredible partners, STAND, TB Care, a lot of amazing harm reduction policy programs and organizations that give us support, that stand alongside us as allies, and also some incredible networks in South Africa of as people use drugs. And some examples of this is in some of the work, as well as the toolkits and trainings that target healthcare workers for sensitization, law enforcement trainings, and then also trainings and sensitization for key role players and stakeholders. An example is the Pregnancy and Substance Use Toolkit. Shout out to Julie and colleagues who pulled this together, as well as community advocacy initiatives that bring communities from all walks of life together. A shout out to Shanae Roberts back home. She has led on this amazing advocacy initiative for a few years now, called FemAlive. We come together, we invite communities, women, we get packs together, we hand out from anything from sanitary pads to t-shirts, and then also bringing law enforcement together in a different space. There was an amazing session where there's plans for self-defense, having a police official coming and chatting with us at this space prior to the walk, around how better to protect ourselves. And it's just through copious amounts of advocacy, a lot of passion, a lot of love, that we're able to engage role players like specific police officers in areas, so that we can again move away from this punishment and looking more towards supporting people. So yeah, the FemAlive walk is really something beautiful, and just one of the many examples. And the last one is something we did a few years ago, which is activities again for women by women, where we went out and we aimed to remind one another that no matter what, no matter who you are, what you do, you're worthy of love, deserving of rights, and beautiful. And that was, and I think maybe we can move on to the next slide. It's a little bit, it's not as positive, but if we can move on one more. There we go. Unfortunately, this isn't as positive, and it's just kind of coming back. I think a lot of people have been bringing and raising this, but the termination of grants from the USA, as well as Europe, or a number of European countries redirecting their funding, is threatening lives of communities, and it's impeding on really incredible work, life-changing work, life-saving work. Methadone is a life-saving medication. Needles and syringes, safe stimulant packs, it's life-saving and life-changing. And this has been either ended or is on the brink of being ended. And also, it's purely programs that are suffering, not just organizations or civil, sure. So just quotes, and shout out to Catherine Cook from Harm Reduction International, and everyone who helped bring some of these key points together. Is community organizations and peer workers, the backbone of harm reduction services, are the hardest hit. These cuts are cruel and short-sighted. Treatment will cost governments and donors far more than continuing this life-saving prevention services. Therefore, we implore that governments step up and use domestic budgets to close the service gaps, and support community-led and civil society harm reduction. Donors must prioritize strong pledges to the Global Fund, and governments and donors must stop spending vast amounts of money on punitive approaches and invest in harm reduction. There's one more slide and then, yeah. So in summary, we need to be removing biases, expanding on sensitizations and conversations. We need to be prioritizing human rights, collaborating with role players, coming together and creating change together, but also embracing humanity, including flexible funding that is peer-defined, peer-implemented, and of course, peer-driven. And that's the only way we can ensure meaningful involvement. That's the only way we can ensure meaningful change. There's a thank you slide at the end, as well as some key reference documents, including this Femini book, one of the many. And yeah, if you like, you can check out our website. There's a really amazing toolkit and also some more info on some of the work that we've been doing. Thank you so much.
Thank you, Angie. That was great. I mean, everything you've talked about, especially the toolkit for pregnant women, I don't think a lot of people have done that. Also, I'd like to thank you for highlighting the importance of the involvement of communities in responding to the particular needs of women who use drugs. The participation of affected communities is key in the design, in the planning, and the implementation of services that are tailored and that actually respond to the particular needs of women and gender diverse individuals. Teresa Castro is best placed to talk about this particular topic, as she is a social worker from Portugal with living experience of drug use. Teresa is a member of Youth Rise's International Working Group and peer collaborator at Cosmic Care. She's going to bring us the perspective of a country that has decriminalized drug use, but where barriers still need to be overcome to ensure women and gender diverse people have access to harm reduction services. Thank you, Teresa.
Good afternoon. Thank you for inviting me to speak at the side event. For the purposes of this intervention, I will use the term women to refer to cis women, trans, and gender diverse individuals. I am a member of the International Working Group of Youth Rise, a global youth-led network that advocates for the health, rights, well-being, and inclusion of young people who use drugs in policies and programs that affect us. We work to ensure that our voices are heard in global drug policy discussions, and I am grateful to contribute to this conversation today. So I come from a very different context from the other panelists. So I want to begin by acknowledging my privilege as European, cisgender, white women, with family support, with stable housing and employment. These are all advantages that many do not have. I would also like to highlight how no woman who uses drugs exists as a singular and isolated identity. I'm a young person, I'm a woman, I'm a social worker, I'm a person who uses drugs. This complexity shapes my experiences, challenges, and perspectives. However, as a social worker working in harm reduction in a country recognized for its progressive drug policy, I witness firsthand the realities faced by marginalized women. While Portugal's decriminalization model has significantly improved the health and well-being of people who use drugs, today's discussion is an opportunity to reflect on the challenges that different communities still experience, such as disproportionate violence, institutional barriers, and trauma. I have seen how this population is excluded from shelters, including those for survivors of intimate partner violence. In many cases, abstinence is still a requirement, and cis heteronormative rules do not respect gender identity and expose people to further harassment and violence. There are approximately 50 accommodation responses with 800 places for survivors of intimate partner violence, but there is only one with 9 spots, which is constantly full, dedicated to trans and gender diverse individuals. These strict binary policies also exist in the prison system and restrict access to proper healthcare. I understand why this community in particular distrusts my profession. Social workers should advocate for clients' rights, yet too often are used as agents of surveillance and control. To build a trusting and horizontal relationship with service users, I found that being and disclosing that I am a young woman who uses drugs help me to bridge gaps, even if our drug use patterns and contexts may differ. I have experienced how young women who use drugs face compounded stigma due to adult-centrism, being labeled as irresponsible and immature, which is used to deny our autonomy and decision-making capacity. This perpetuates moralistic and paternalistic interventions that prioritize prevention and abstinence. In Portugal, people who are caught with a quantity of drugs that's considered for personal use must present themselves at dissuasion committees, structures that offer an alternative to courts. In 2022, it's the latest data we have, most cases resulted from cannabis use possession. Most individuals were classified as non-dependent, and most were young people between 16 and 29 years old. The percentage of referred women was the highest since 2013. Those classified as dependent can have their process suspended if they agree to treatment. So this system maintains the idea that drug use has to be punished and contributes to stigma and social exclusion. At the same time, patriarchal narratives dismiss women's pursuit of pleasure, reinforce gender power imbalances, and negative stereotypes. Harm reduction is still focused on adult men who inject opioids and overlook the specific needs of diverse genders, ages, substances, and routes of administration. So to conclude, the other slide. I would like to highlight 3 recommendations for addressing gender inequalities and vulnerabilities in line with the international guidelines on human rights and drug policy. So to develop inclusive intersectional policies, currently the public funding mechanisms don't allow for intersectional approaches. So they should ensure that meaningful participation and leadership from affected communities is possible. The services must be gender and age responsive, trauma-centered, low threshold, free from conditions like abstinence or age restrictions or parental consent. These only marginalized people. It must be offered training for healthcare providers and social service workers. The second, address social determinants of health. So as a social worker, this is very important for me to stress this systemic barriers that prevent people who use drugs from improving their lives. Women may face economic inequality, financial dependence, violence, discrimination, and acknowledging these factors will allow us to address root causes and design effective harm reduction strategies. The last, to go beyond decriminalization. While it is an important initial step towards reducing harm, it does not eliminate stigma by itself. It does not eliminate institutional barriers or the lack of tailored services. If it's not accompanied by a structural reform that guarantees access to services and protection against discrimination, it will only serve as a means to alleviate negative legal consequences. So we must see it as the beginning of a broader transformation rather than the final solution.
Thank you.
Thank you so much, Teresa, and thank you for highlighting that decriminalization is not the end goal always. It's a starting point for a lot of us. It's very important, but yet funding and harm reduction services still must be made more accessible for women and gender diverse people. Finally, last but not least, I'm going to give the floor to Fionnuala Murphy, who's the head of global advocacy at Frontline AIDS, and who are also our co-organizers of this event. Thank you, Fionnuala. I'm so sorry, we're already over time, so if we can keep it down to 3 minutes, that would be great. I'm sorry for not moderating the time properly.
Not at all. It was an excellent event, and I want to say congratulations to everybody that was part of it, and thank you for giving me this space. I am, both on behalf of Frontline AIDS, but also simply as myself, as Fionnuala, I am really, really grateful to have been here and listened to the presentations today. And I want to reflect back a few recommendations that I've heard. We just heard from Teresa about the importance of intersectional policies, and that's a key one. Investment in harm reduction fundamentally is critical. It saves lives. Investment in integrated approaches that bring harm reduction together with gender-based violence and SRH services for women who use drugs, and really gender transformative approaches for women from that community is so important. I want to repeat what I've heard from several speakers about the vital importance of investing in services that are led by and for women who use drugs, because those are the services that will make the biggest difference. Why? Because women themselves know what they need. And for me, this leads to what I think is a really critical point across this whole area, which is that it really is high time that we started listening to women who use drugs and that we stop judging them. We know that women who use drugs experience double judgment. They experience double the violations of their human rights. They are doubly criminalized and punished simply because they are women, and this has to stop. And Angie pointed to, and they're also doubly denied health services. And Angie pointed to some really useful tools that are already out there, like the tool for pregnant women. It's time that we started listening to women and using those tools. I wanted to say as well that in the context that we're in right now, we've had years and years of chronic underfunding of harm reduction. Now we're seeing catastrophic US funding cuts, and we're also seeing that the rights of women and of key populations are really directly under attack. And in this moment, governments need to do a lot more with a lot less money. So the impetus to stop criminalizing people who use drugs has never been greater. We have to stop wasting money putting people who use drugs in prison, period. And don't put barriers in the way of effective responses. Decriminalize people who use drugs, decriminalize women who use drugs. Spend your money on health, evidence, and human rights-based responses that will meet women's needs and respect their dignity and their humanity. On the theme of that humanity, I just want to close by dedicating my remarks in this event to a woman that I used to know years ago when I lived in London. She was an Irish woman like me, and she lived in the streets around the area where I lived. And when I had my son, that was when I really started to see this woman and really get to know this woman, because every time I passed with my baby son in the carrier, she always waved to him every single time. And there was such incredible tenderness in that gesture. And when my son got bigger, he always waved back to her, because even a baby should be able to see the humanity that is in every person, including women who use drugs. And it's high time that we asked ourselves, why do we accept the dehumanization of women who use drugs? Nobody could put it better than Angie, who said, women who use drugs are worthy of love, they are deserving of rights, and they are beautiful. Let's remember that as we close. Thank you.
Thank you so much for these fantastic closing remarks. And thank you everybody who has attended both in person and online. Thanks. And thank you to our panelists so much.
Thank you so much. Thank you to Michelle as the organizer as well. You've done a brilliant job.